So we are going to go ahead and get started with the webinar, Reflux, Silent and Not So Silent, What You Need to Know. My name is Elizabeth Aloni, and I'm with Schneps Media. Schneps Media is the largest media company in the New York metro area. We publish over 70 newspapers, magazines, websites, webinars, podcasts, and events, and do so throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, and Philadelphia. Today, I'm thrilled to be able to bring you an expert who can talk about reflux, which is a disease that affects millions of people every day. And so we have a wonderful expert who's going to share what we need to know. I'm pleased to introduce Craig Zalvan, MD, FACS of ENT and Allergy Associates. Welcome.
Thank you very much.
Absolutely. Let me tell you a little bit about Dr. Zalvan. He is also presently the medical director at the Institute for Voice and Swallowing Disorders and chief of the otolaryngology service at Phelps Hospital, Northwell Health, where he also serves on the board of directors for the hospital. He's one of the co-directors of the newly opened Reflux Institute at Phelps Hospital. He is a clinical professor of otolaryngology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell and lectures internationally and nationally with numerous presentations, publications, and research projects. We're certainly very happy to welcome him here with us today. So let's jump right in. Dr. Zalvan, what exactly is reflux?
Well, reflux is a very broad topic, and everybody has heard this term before, and it's something that I think most of us either have had or know somebody who has quite often. And really is a lot of confusion with this disease because it's all sort of lumped together as one problem, when in fact there's really a spectrum of different types of reflux disease. And what everybody is very much aware of is GERD, or gastroesophageal reflux disease. And that's a common symptom, such as the heartburn and indigestion. But what's less known, and frankly, probably more common, is reflux that affects the throat. And that has many different names: silent reflux, reflux laryngitis. And the reason it has so many names is because there's a lot of confusion with this problem. But the name of this type of reflux is Laryngopharyngeal Reflux, or LPR. And again, reflux that affects the throat. And in my area of expertise, I'm an ears, nose, and throat doctor, but I specialize in the throat, called a laryngologist. And a lot of what we do is voice, swallow, cough disorders, many of which are caused by reflux disease, this LPR.
Interesting. So LPR is what silent reflux is, and it's something different than what we typically hear or think about when we think of reflux.
That's correct.
Why is it important for people to identify who have LPR, and how does this reflux affect us specifically?
So, I think the importance is the recognition of this disorder. And I think I'll talk about sort of some of the symptoms, and then we can get into why this is important. LPR, and again, first, just to backtrack, GERD, again, the common disease, heartburn, indigestion, early satiety or fullness, some pain or discomfort in the stomach. Those are common symptoms that are frequently seen. And as you said, there are millions of people at the cost of billions of dollars every year to diagnose and treat this disease. Well, LPR is a different disorder, though a spectrum of reflux. And the most common presentation people will complain of symptoms such as chronic throat clearing. Doc, I got something stuck in my throat. I feel mucus in my throat. Recurrent coughing, especially coughing at night, is a sign of this LPR. Some people complain of chronic discomfort or soreness in the throat, some trouble swallowing. Some people will feel that they're constantly getting a postnasal drip sensation. They feel dripping in the back of their nose. Now, I'm telling you all these different symptoms, and many of you are thinking, well, wait a minute, I have a lot of those symptoms, but I've been told it's allergy or asthma. A lot of people with reflux that affects the throat area have breathing issues. Not only can acid exacerbate underlying acid, but it can also cause some sort of irritation of the lungs and the windpipe that could even cause its own type of breathing issues or reactive airway issues. So the importance of understanding reflux disease when it affects the head and neck and throat area is it can often be confused with many other types of diseases, such as allergy, asthma, sinus disease. In addition to those symptoms, when people have chronic acid exposure, whether it be kids, young adults, adults, and older people, it can cause a lot of other exacerbations or problems, such as ear infections, recurrent sinus disease, dental issues, and then again, the whole spectrum of diseases I just mentioned, in addition to chronic acid exposure, can lead to the onset of cancers in the throat and the esophagus, which is, again, really why we want people to be aware of this disorder, so that we know that when people have this for long periods of time, we're looking to diagnose, identify, and then treat the disorder so that we don't progress to those stages.
So let me ask you something, because you just said something that kind of made my head go, which was that you're saying that someone who has asthma or some of these other illnesses or diseases, you're saying that it could also be reflux. And so they may find that they're not getting any relief from medications for that disorder yet, because they're still being undiagnosed. So can you have both at the same time? And is that common?
Yeah, so it's a great question. And the answer is yes, you can have both. And there are clearly people that have asthma, documented asthma, abnormal pulmonary testing, response to medication. There are people that have chronic sinus infections, chronic respiratory issues, chronic ear infections, which by itself is a disease process. But we know that chronic exposure to acid, which is an inflammatory compound that can irritate those structures, can lead to worsening of many of those symptoms, but also can cause many of these issues by itself. So we take those same people who are treated for their ear infections chronically, and they keep coming back, and people who have allergies that just don't seem to go away, certainly breathing issues that may respond to some medication, but still always have some baseline breathing issues. And then you throw in a lot of those other symptoms that I mentioned earlier, the throat clearing, the coughing, the swallow issues, sometimes voice changes. And that makes me stop and think, is there something else going on that might be causing or exacerbating these other underlying illnesses? And that's where the role of reflux comes in. So basically the message in this situation is, if you have a problem, certainly the upper head and neck area, and you've been treated, or you're getting better, but you still have symptoms, or you still have treatments that you've tried multiple different things, reflux disease is one of those problems that you should consider and think about, again, especially in light of some of those other symptoms. Because if it's identified properly and treated, then a lot of these other diseases can get markedly better. So it's very common that I see, kids come in with recurrent ear infections, and you treat them just for acid reflux and their ear infections go away. Same thing with, adults with chronic sinus disease. A lot of that postnasal drainage sensation. It's interesting because we all have postnasal drip. Everybody walking around drips 1 to 2 liters of mucus every day. That's a full of that stuff. And that just drains into the back of our throats. The difference is a lot of people who complain of postnasal drip actually feel the drainage. Because right now I'm talking to you, it's dripping back there, but I don't feel it, neither do you. But a lot of people do, and that leads to this sensation a lot of people get. Does not mean it's postnasal drip syndrome, because there's no such thing. Postnasal drip is normal. It's just some people feel it, or they have an underlying sinus issue or allergy issue that's a real issue that increases the amount. So my point is, for people who have chronic symptoms that really don't respond as you would like them to, one of the factors that may be present is reflux disease, both as a cause and exacerbating factor.
Very good to know. Very good to know. So how would you diagnose LPR?
So, it's an interesting disease to diagnose, because most people with both GERD and LPR are diagnosed based on assumption, meaning somebody will come into the office, they'll complain, whether it's heartburn, indigestion, or doc, I got a chronic cough, or, I'm feeling something stuck in my throat. And that's sort of the initial diagnosis that people get, usually from their medical doctors. the way we diagnose this, and that's fine, because in many cases they respond quite well, they get better, and there's no further issues, assuming they're not needing medication long term. And we'll get into medication in a little bit. What I do is diagnosis is really two major factors. And most important, of course, is this history. What you tell me in the office setting, what your symptoms are, how they correlate to what I see. We'll talk about that in a second. And also, of course, how you respond. That's the diagnosis. It's really in the history. And we know in medicine, as the dictum, that 95% of what's going on is going to be in the history. And, our physical exams just sort of push us in the right direction. And then, of course, the other testing. So what we do to look, the only way to evaluate the throat really is to look with a small camera. And we have very small cameras that go through the nose. And a lot of people are afraid of this camera. I've done it to myself many times.
Wow.
Doesn't hurt. And what it does is it allows us for really good visualization of all the sinuses, because of course that could be an issue, but also a direct visualization of the throat, the vocal cords, the voice box, the windpipe, and the top of the swallow tube. What this does is this gives me a view of your entire throat. I can look and then say, oh, well, there are some of the characteristic findings that certainly suggest reflux is present. And based on those findings and the lack of other findings, such as inflamed sinuses with drainage of diseased material, then I'll say this is reflux, given your history and these findings. And then my approach is let's treat. And if people respond to treatment and they do well and their symptoms resolve, then we pretty much are done with the diagnostic workup in many cases. Now, there are some people that, despite what I think is going on for reflux, may not respond. Or people come in who've been treated before or on multiple medications, and they're still having symptoms. Then there's a way we can actually measure the acid. And it's a procedure where a very small catheter is put in the nose. Again, I've done this to myself many times. Don't ask.
Wow.
And, truthfully, anything I do to my patients, I have done to myself, so I know how it feels. And I think that helps make a patient feel more at ease. But this catheter is worn in the nose for 24 hours, and it measures all the acid in the throat. How much, how often, how severe, and more importantly, does it correlate with the person's symptoms? And that helps me make a decision whether acid is present, clearly if there's a correlation with symptoms, or there may be no acid present despite having lots of symptoms. And that helps me go down a different pathway, thinking this may be more of a neurosensory issue where people could have hypersensitivity leading to a lot of these symptoms. There's also another diagnostic test that I'll often do in patients with chronic reflux. Typically, people I diagnose with reflux, I like to look in the esophagus. And the reason I do that is because we know that there is definitely a portion of usually older patients. This is certainly not in your 20s and even 30s. But once we start getting into the 40s and 50s, we do know that there's an increased incidence of esophageal cancer present and also precancerous conditions. And I do office-based esophagoscopy called TNE, Transnasal Esophagoscopy, where I put a camera in the nose and it goes all the way down into the stomach. We take a look around and then you can drive yourself home 5 minutes later, well, give or take. The thing is, it's a pretty simple procedure that I can perform. You're awake for this. It is mildly uncomfortable. I've done this to myself as well, well tolerated, and it gives me the full picture of what's happening with your issues in your throat, and I can see your anatomy from the nose all the way down to the stomach. And this is sort of the major diagnostic workup that I do for somebody who's presenting with these symptoms, who may or may not have reflux. And don't worry, not everybody needs to have these things done. The vast majority can be diagnosed based on their history and their physical examination. And of course, there are many other tests that we utilize in my field in particular for people with chronic ongoing swallowing issues, voice dysfunction, coughing, etc. And what we find dictates sort of that testing paradigm that we utilize to try to arrive at that diagnosis and therefore treatment.
I understand. So number one, don't be afraid of these diagnostics, because they're very mildly uncomfortable, and yet they can reveal information that's critical for you to feel better. You mentioned the one that goes down to your stomach. Is that the same thing as an endoscopy? Because I know that when people have heartburn, very often they're sent to get an endoscopy. Is that the same, or is this a little bit different?
It's a little bit different. What we call this is transnasal esophagoscopy, and the primary goal is to evaluate the esophagus. When people go for an endoscopy by the gastroenterologist, they're typically put to sleep with IV sedation, which, you're sleeping, there's not movement, you're lying down on your side. That kind of changes the normal anatomy a little bit, but that gives a full evaluation of not only the esophagus, but the stomach and small intestine. And clearly for people with abdominal issues and abdominal upset and many of these symptoms, that is absolutely the indicated test. Transnasal esophagoscopy is more of the tool that we laryngologists use to evaluate the esophagus and help work up when patients have chronic coughing, chronic throat-related symptoms such as lump in the throat feeling, or other findings of acid that prompt me to take a look. Because as I said earlier, there are definitely a subset of patients that have only these throat symptoms and can have significant abnormal findings in the esophagus without the typical symptoms of heartburn or indigestion. So if people are coming in with, say, a chronic cough and they have no other symptoms, they may not get an endoscopy for many years. And we want to look earlier than that to make sure there isn't anything else going on in the esophagus. So they are very different tests. They have about the same sensitivity and specificity, which means I can look in the esophagus and arrive at the same diagnosis as the gastroenterologist would. We can also do biopsies and procedural interactions as well. But for the most part, this is a good screening tool. Typically, when I find significant abnormalities of the esophagus, I will be referring them to my partners who are the gastroenterologists to help manage and also do further evaluation if needed.
Got it. Okay. So there's a very popular pill. It's this little purple pill that a lot of people are taking. I see advertising for it. Do you recommend this for LPR?
So, this is a couple hours of conversation to talk about this pill and certainly many pills. The short answer is this pill was created back in the 80s, the whole group of proton pump inhibitors. And from a medical pharmacological point of view, they're amazingly successful. They do their job. What they do is they suppress acid secretion. What they don't do is stop reflux. So there's a difference, because less acid clearly means there'll be less irritation of the structures. But certainly with reflux in the throat, our throat structures are not well protected against acid. So therefore, even a slight amount of acid can be enough to cause irritation and chronic changes. So my approach to treating reflux has really changed over the years. Going back a decade ago, I was probably one of the largest prescribers of this whole group of drugs, including the little purple one. And over the years, I sort of became very frustrated with seeing patients come in with many of these throat-related symptoms and writing the prescription for a pill. And then typically what we see is, well, that pill's not working, so let's give a different pill. Oh, but wait a minute, still symptoms, so let's double the dose. Still not working, well, let's add on another type of medication. And this to me became very frustrating, because although some people were getting better, most people require these medications long-term. And unfortunately, any medication long-term has the potential to cause side effects and lead to other problems. And certainly there's a lot of controversy with the whole class of drugs, the proton pump inhibitors. And over the last decade, there have been many publications that are typically studies that look at data from large populations, retrospective, looking back in old charts, and sort of population data, not the true gold standard where we take two groups and we blind them and compare the results. But a lot of these studies show that there are potential long-term risks of using these medications, and that includes things like pneumonias and bone metabolism, fractures and whatnot. But also in the last few decades, there's been a number of other diseases, such as possible increased risks of certain cancers, such as stomach or esophagus, and linked to other diseases, such as heart disease, kidney disease, and most recently, COVID. There's been a couple studies linking being on these drugs to increase risk of getting COVID. Now, of course, I don't want everybody to stop their medications. That should only be done under the guidance of a doctor. But this whole issue with medication and the need for it sort of struck me as this just doesn't make sense. And that's kind of where I sort of started deviating as far as how I would treat. And, a group of us did some research a few years ago looking at what might be some of the other causes of reflux. And that's how we've come up with sort of a new way to treat reflux, which really addresses the cause, which is the diet. And that's the approach that we take. Sort of sounds like a segue into the next question.
No, please tell me more about that, because I find that exciting to hear about the way to be able to prevent.
So what we found is, what I did is I went back and I looked at the chronic disease literature. And when you look at all of our population, certainly in our modern westernized societies, we have very high levels of heart disease, diabetes, stroke, and cancers. These are chronic diseases that we've got many drugs for, many surgeries for it, yet the rates of these diseases and their complications still is quite high. And in the chronic disease literature, there is a lot of literature that looks at how diet plays a significant role. And, again, this is a talk that we could go on for days discussing, but the general feeling and what is supported by the data and the literature is that, we're a highly animal-based society that eats lots of animal-based products. And it's that chronic exposure that leads to chronic inflammation. And in this particular case, reflux. So the inflammation leads to chronic disease states, which then in turn results in the chronic disease. So I'm thinking, if the Americanized diet causes all these different diseases, it makes sense to me that it also causes reflux. And we did do some research, which was published in JAMA, showing that we can treat reflux, laryngopharyngeal reflux, LPR, as well, if not better, with a mostly Mediterranean plant-based style diet, with the addition of alkaline water and the standard dietary precautions. So let's just sort of break that down for a minute. Yeah. So everybody has heard with reflux that you got to avoid coffee, tea, chocolate, soda, greasy food, fried food, fatty food, spicy food, alcohol. Sorry, I know everybody loves those things.
Yes. Sounds like a great party.
I don't think those cause reflux, but they're all triggers that can exacerbate somebody with an underlying reflux problem. So in my mind, I do have my patients stop those and certainly curtail them, at least for now, while we're treating and getting people better. So I do think that that's important, at least initially, but I always tell patients that, sure, once your problems are gone, those can be put back in within reason. Obviously, you abuse anything, you're going to have problems from it. And even seltzer, by the way, seltzer is a pure acid. It is carbonated, which can cause reflux, and it's acidic. So the goal is, let's avoid those. I also have my patients drink a lot of water that's alkaline, the opposite of acid. Now, there's a lot of information in the internet about the health benefits of alkaline water. And I don't believe much of that is true. But when it comes to neutralizing acid, if you drink water that's alkaline and there's acidity in the throat, and that pepsin molecule, which comes from the stomach, which helps digest protein, that will inactivate it. So alkaline water is a nice tool. I also use a lot of compounds that coat the throat and the esophagus that are called alginates. Reflux Gourmet is one brand, Gaviscon Advanced, which is available on the internet, or you can buy it from a small country called Amazon. And what that will do is coat the throat and the esophagus, and that helps to bind acid. And then, of course, the crux of our research showed that by taking these measures and putting people on a mostly Mediterranean plant-based type diet, figure 90–95% plant-based, cutting out the dairy, the meats, the chicken, fish, eggs, pork, steak. And by the way, they're all the same to me. I don't say any one chicken is better than steak. It's all the same. That's what causes chronic disease. That's what causes reflux. So by doing this, our data shows that our patients did as well, if not better, on the dietary approach than taking the medications. And think about that for a second. So they're not only doing better on a diet approach, but the side effects of the diet approach are long-term, less diabetes, less stroke risk, less cancer risk. It's healthier, and certainly heart disease. So that's the positive side effect. In addition, many of my patients, the average will come back and say, hey, doc, I lost 8 pounds over the last couple of months. Because it's a healthier diet, people tend to lose weight on this diet, a side effect a lot of people like. In addition, stopping medications, and we'll talk about that in a second, is cost savings. Clearly, you save a lot of money on these drugs that cost billions of dollars a year to society, but also will get rid of those potential risks of being on medications long term, including side effects with other medications. And what I do with my patients is, I don't want anybody who's listening to this to say, oh, I'm never taking this medicine again, and stop it. I can warn you that a lot of people on these medicines long-term, the proton pump inhibitors, if you stop it, you'll have immediate worsening symptoms. It's called the rebound effect that a lot of people do have. So in my mind, by making substantial changes in diet, resolution of symptoms, that then sets up the stage to help with weaning off the medication in a manner that makes sense. And of course, should be done with your physician, with your gastroenterologist. There are people that do have changes in the esophagus that at least the current gold standard is to stay on these medicines long term. That would be Barrett's esophagus. So I do not want people to stop taking medications without the guidance of their doctors following these issues to ensure that they also resolve as well.
That makes a lot of sense. So it's important for people to discuss this with their doctor, that there is an approach that either along with or eventually in place of medication is your diet, and that you're seeing a lot of success with it, not only for reflux, but also you get that effect across many different diseases because it's just a healthier way to eat. I love that, because when you were talking about the PPIs, about how they really don't cure you, they just mask it a little bit, and they really can't eliminate the problem. So yes, those are helpful, but to be able to put this diet into effect could be very beneficial. So thank you for that. And yes, we do want everyone to know that we're not trying to give out medical advice for you in particular. This information is general, and this information is for you to learn more about reflux and be able to discuss it further with your doctor, and think about other alternatives and discuss them with your doctor. But it is very important that you do discuss it with your doctor, because everyone is different. Everyone has a different situation. So
I'm sorry, just so these medications clearly do have roles. I think, what we do with our pharmacology and our different medications is quite amazing, all the different drugs that have been created. And certainly they've helped save lives and have helped people with lots of symptoms. So there is a role. It's just, I believe that a lot of these medications, especially the PPIs, once people are on them, that's it. That's the end game. They stay on them for decades. And, what I'm saying is there's a better way that also has other benefits, health-wise. So it's one of those things to make you stop and think, could we try something different? And that's sort of what I focus my practice on, is not only treating people's problems that affect their throat, but also helping them to get off these medications. And again, going back to my statement, I was once one of the largest prescriber of these class of drugs. Now I routinely are taking people off these medications when appropriate, almost on a daily basis.
Wow. So you were saying one of the things that you looked at previously, because I was just thinking about this in terms of diet and choices people are making. How much does your family history play into reflux and surrounding illnesses?
Sure. So, well, families tend to eat the way they've always eaten. We follow our diets our parents did and their parents did. And, again, our society really is geared towards having diets that are high in animal-based protein. And, our fast food chains are out there. I mean, obesity is out of control. And what's really worrisome is we see that in our younger populations now, obesity is increasing at a too fast a rate. And again, we're sort of trained to eat the way our parents ate and our friends eat. So I think that's the biggest issue here. Certainly genetics play a role with a lot of what happens to us, but they're a lot less of a role than people really know. There are many factors that can predispose to reflux disease. Obesity is clearly one of the big ones, but there are other things that can happen too. The esophagus sometimes doesn't work as well. And then interestingly, there's a whole bunch of patients that have many of these symptoms I mentioned earlier: the throat clearing, the lump in the throat, something stuck there, chronic cough. And these can be due to changes in the sensitivity in the throat. So much like people now know COVID can cause loss of smell, we know that viruses can affect nerve function. A lot of my patients who've been treated for months, years, even decades come in with these chronic symptoms, and it's not because of acid, it's because of their throat is extra sensitive, hypersensitive, often due to a virus that caused that hypersensitivity. And even a little bit of acid feels like this to them, or a little bit of mucus feels like this and triggers their symptoms. So, I think genetics certainly plays a role with a lot of our diseases, but much less so with reflux disease. It is far more of an environmental and behavioral disease than it is genetics.
Very interesting. So really goes to show you how much power potentially you can have over this disease from occurring and reoccurring.
Absolutely.
Fantastic. This has been, we have so many questions. I want to see if we can jump to some of them, because this is your wealth of knowledge. And I want to get to some of these questions because people are dying to know so. Let me jump in here. So Anne was asking about the side effects of medications in terms of bone density loss. Are there side effects to these medications that people are on that they should be aware of?
Sure. So, specifically talking about the proton pump inhibitors, the PPIs, that's the purple pills, the omeprazoles, the pantoprazoles. There's side effects that are quite common. People get some abdominal discomfort, some nausea, some people get some headaches, constipation. That is typically transient, short-lived, and it goes away in a few days and people do fine. Those are really not the complications we worry about. There have been a number of studies that look at bone metabolism and fracture risk and pneumonia risk by being on these medications long-term. And the data does suggest there likely is some increased risk conferred by being on these medications. Again, this is data that's typically looked at in the past or retrospectively with larger populations, and they're very hard data to interpret because there's not a lot of really great controls. In addition, if you look at PPIs for reflux in the throat, the data doesn't really support that they really help reflux in the throat. And again, it's large-scale meta-analysis data, which pools multiple studies. Again, over the last few years, decade or so, there have been many studies that came out saying that there's an increased risk of heart disease, increased risk of dementia, stroke, there's increased risk of kidney disease, liver issues, et cetera, including increased risk of COVID. These are population-based meta-analysis, retrospective studies, looking at data sets, big data, computer analysis. So it's hard to say that you take this pill, you're going to get this problem. That's not what we're saying. What I'm saying is certainly being on this medication potentially could increase your risk of some of these problems if you're on these pills for long term. And why do that if there's another way, a healthier way? Interestingly, in a lot of these same studies, they looked at H2 blockers. H2 blockers are drugs like ranitidine and famotidine, which stop stomach acid secretion with a different mechanism. These are drugs that have been around for far longer. And in all these different studies, there's really no evidence that the H2 blockers long-term lead to any of these disease states. So clearly safer medication. And again, they're great drugs. I use these as, in a sense, Band-Aids to help transition people off of PPIs and onto a better diet, eventually stopping the H2 blockers, or using them if necessary for longer periods of time because they are a safer medication.
So look, medications play an important role very often. And, speaking with your doctor about the side effects and about the benefits versus the difficulties is an important conversation for everyone to have. Thank you for that. Suzette, oh, sorry, go ahead.
To throw in sort of like a corollary is, you look at type 2 diabetes. This is the diabetes that people get because they get older and they become obese and they need to take medication. That's a disease that is preventable in the vast majority of people who get it. And it is clearly a diet-based disease. So yes, you can go on medications. You can inject insulin and be on these medicines for life. And I think every day you see all the commercials on TV for all the new medications that are out there, again, at the cost of billions of dollars. Or diet alone can reverse much of this and certainly prevent the majority of this type 2 diabetes. So this is sort of the same paradigm where reflux disease is yet again another chronic disease that can be prevented and treated with a diet-based approach.
Very important. Thank you. Suzette wanted to know, she said, I suffer from anxiety, and for some reason, whenever I have a panic attack, I seem to have reflux before or after. Is there a correlation?
So it's interesting, and there could be many mechanisms for that, but we do know that anxiety can certainly heighten reflux by itself, but also can heighten the sensitivity. So people who are anxious may be more sensitive. So if there is a little bit of acid that comes into the throat, for instance, it may feel like a lot more acid for somebody who is anxious about their symptoms. There are clear studies that show when you look at the brain's activity that there's heightened areas of activity that are responsible for our sensitivity elsewhere that are found in people with higher anxiety. So there is definitely that correlation where anxiety can lead to hypersensitivity, and then it becomes this vicious cycle. You're more sensitive to a symptom, you get more anxious about it, it makes you more sensitive. And of course, we know stress and anxiety is a major factor for a lot of us. And we're all busy, we all have busy lives, a lot's going on. I mean, especially after this year and a half, that stress can induce a more acidic state with more reflux and again, more heightened sensitivity.
Good to know. Thank you for that. Joel said, wanted to know, he has acid reflux and IBS, wanted to know do you recommend sleeping with a wedge pillow? Does that help?
There's a lot of things that help. And again, just like I look at medications, there are a lot of these Band-Aids that people can try. So certainly there's a lot of behavioral modifications. So in some people, putting a wedge, that not just a pillow, because people roll and pillows go everywhere, but they do make some pillows that sort of conform to the body and keep the body more upright, or raising the entire bed, putting the bed on some blocks. Again, a nice Band-Aid that may help. Other things, don't wear tight clothing. I tell my patients, don't eat and then lie down. That's just the wrong thing to do. Wait at least 4 to 5 hours. The other thing is, in our country, what's our largest meal? Dinner. So switching that around a little bit to have more frequent, smaller meals and avoid that larger meal in the evening may be more helpful and beneficial for people with chronic recurrent reflux. But again, diet is the key. Switch the diet, then you're not going to need to have these measures in many cases.
Great, thank you. Suzanne said she's been diagnosed with esophageal erosion and she's being treated by a gastroenterologist. Should she also be seeing an ENT specialist?
Well, the answer is no. If your symptoms are purely esophageal in nature, stomach in nature, those GERD symptoms, and your GI guy is monitoring this and watching to make sure this doesn't progress to anything else, then no, you don't need to see an ENT. I'm here to say, as an ENT who specializes in the throat, we treat the symptoms of the throat. So if your main reason is chronic coughing, for instance, or throat clearing, lump in the throat, also called globus sensation, then that's something that I treat. But if it's purely esophageal irritation, I'm not quite sure what erosion is, but if it's an irritation that's there, then certainly, the GI doctor should be able to, monitor that and treat that.
Terrific. Lois said, I feel like there's a drip in the back of my throat, but when I eat, I feel as if the food can't get down fast enough and I keep choking until it gets down. Are these symptoms of LPR?
Well, in a sense, yes, they can be symptoms of LPR. Reflux nowadays is that's blamed for every problem that's out there. And, really everybody I see who comes in has been treated and put on these drugs because their symptom has been told due to reflux. So this is a swallowing issue, and swallowing issues are clearly very complex problems that do need to be further evaluated. So certainly somebody who's coughing and choking on food, that suggests something else is going on with the swallowing mechanism. And there are many, many reasons why that can occur. And that, again, is sort of the specialty of the laryngologist, that what I do to work this up and figure it out. Muscle dysfunction, acid reflux absolutely can exacerbate that. Another common thing I see is hoarseness. People are hoarse, they go to the doctor, the ENT says, oh, it's acid, take the pill. Reflux does not cause hoarseness by itself. It certainly can exacerbate, but there is almost always another cause that is making the person hoarse, and then acid reflux can exacerbate that. So look for the other cause. And much is true for people with swallowing related disorders.
Great, thank you. We have a question. Do you recommend any alkaline water brands? I mean, I don't know how do you find alkaline water? Is it available everywhere?
And basically, for me, the brand doesn't matter as much as I like it to be more natural occurring rather than something that's made in a lab somewhere. And also pH, the value of acid, the pH value should be greater than 8. That's pretty much the criteria that I utilize. And there are many different brands that are out there.
And you can get it in a regular supermarket?
Supermarkets, pharmacies, and that big country called Amazon.
Perfect.
And no, I don't own stock in Amazon.
We just all know it's a very big country. Tanya said, what brings about acid reflux? Because out of nowhere, she said she started having symptoms in response to foods that she's eaten all of her life. And, is that something that can be ultimately healed so she can return to her original diet? Or is that something that her diet is now affecting her?
Well, the question is has there always been some mild reflux, but not really symptomatic, and something put that over the edge? That's one possibility. Again, we talked earlier about viruses causing change to sensitivity. They can also exacerbate reflux. They can also decrease the motility or motion of the esophagus, and this could lead to worsening symptoms. There could be the onset of food allergy and sensitivity. The short answer is there are many reasons why people suddenly become symptomatic, and that's sort of what we have to tease out so that we can get you back to what you're used to, though I'll argue probably not the best diet. Again, Americanized diets are not all that healthy. That's why we're so sick as far as the country is concerned. So it's hard to know exactly in your case what happened, but there are many people that have this type of presentation, and it's teasing out the difference or change or what's present that we can then make things go away and get better and go back to some of the dietary behaviors that you've been used to.
Okay, thank you. Tom said that his ENT, he calls it a roto-rooter, but I think it's one of the procedures you're talking about, through the nose to the larynx, and said, I had nodules on my throat due to the coughing. And he said probably due to a combination of allergy and silent reflux. He said, if I change my diet, can he reverse these nodules?
So the short answer is nodules, I find, typically are not common as much as people think they are. When people are coughing, they develop more of what's called mid-epithelial fibrosis, which is, in a sense, thickening of the vocal cords in response to chronic trauma, much like people get calluses on their hands. So it's hard to know what really is going on in the vocal cords, number one. Number two, why are you coughing? So is this due to reflux? Is this due to allergy? Or is this due to sensitivity changes, hypersensitivity? So in this particular case, it's really trying to figure that out. You're the person who I would want to do acid testing on to say, is there acid in the throat or not, and how much, and does it correlate with your coughing episodes? Certainly, if there's acid, then a dietary approach can be helpful as part of a treatment package, ultimately staying on the diet. But this may be other issues that need to be looked into. And once you figure out why you're coughing, cough will go away, and a lot of these changes in the vocal cords will improve as well. Again, it's finding the underlying cause that helps us direct where you get treated.
Thank you. Marsha wants to know, is acid reflux related to diverticulitis?
So diverticulitis is a disease that affects the colon, where from our chronic disease-prone diets, we develop these pockets in the colon that particles can get stuck in, they can get inflamed, and causes recurrent disease. So it's not related to acid reflux disease per se, but it's part of the same dietary cause, meaning our Americanized diet is why people get diverticulitis. You don't see diverticulitis in parts of the world that are really more plant-based societies.
If you haven't heard him yet, diet, 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 diet. People are asking where you can find the Mediterranean diet, and I'm saying you can Google it. It's pretty easy to find, right?
Absolutely.
Terrific. Mark said, for Barrett's, I was told by GI doctor that PPI was essential to prevent esophageal cancer. Do you agree?
So the answer is yes, I do agree. And that is the current gold standard, that once you're diagnosed with Barrett's, especially if there's abnormal cells, that needs to be watched closely, needs to be rebiopsied closely. And yes, the current gold standard is to utilize PPI therapy. There is some question in that in the literature, and no one, including myself, have actually studied our patient populations. Now, I can tell you anecdotally from experience that changing the diet is one of the most protective things you can do to prevent progression to a cancerous state. Now, by no means do I say you should ever stop your medications and not be followed up. Absolutely, you need chronic follow-up and you need to stay on these medications. But over time, if there's reversal of those findings and there is no longer any kind of disease state or what's called atypia or dysplasia, then certainly diet can be very helpful. And in some cases, people can be taken off their medications as long as they're under chronic surveillance by their GI and ENT team.
Right. Always listen to your doctor and change your diet, period, because it's certainly not going to hurt you, and it's going to help you in other ways and can help you in all ways.
Absolutely.
Tom wanted to know, in lieu of alkaline water, can you add baking soda to water? I never heard of this.
Don't recommend it. Number one, it's very hard to make water alkaline enough just by adding baking soda, and there's a lot of sodium involved in that. So again, I like the naturally occurring water that's alkaline. There are a couple of filters that you can buy. There's some thermoses out there that you can buy that make the water more alkaline.
Don't try that at home.
Correct.
Okay. Shari wanted to know, could a dentist identify LPR and GERD?
It's a good question. There are a lot of people that do have some dental erosions because the high acidity is not good for the enamel. Bad breath, halitosis, enamel problems, dental problems can be indicative of a chronic reflux problem. And certainly switching the diet is, clearly going to be beneficial for those diseases as well.
Perfect. I do want to say a couple of people were asking if this was recorded. This is recorded. We will share the link with you, so you will be able to watch it again and be able to share it with others. Sometimes it's hard to tell our family and friends things, but if you show them the video of the doctor telling them, they may be more willing to hear it. What about any other natural, someone mentioned that you'd mentioned some other natural substance that would be beneficial. Do you know?
Well, there's a lot that's out there. I mean, GERD is again, $1 billion industry, and there's also many supplements that have popped up. For instance, apple cider vinegar is a very common one. I do not recommend apple cider vinegar. There is no studies that show that it actually helps for people with both GERD and LPR. And specifically with LPR, the problem here is your tissue in your throat is very sensitive. So acid coming up irritates it. The digestive enzyme pepsin comes up and irritates it, and acid activates pepsin. So by drinking acid, apple cider vinegar, you're actually propagating the disease process. You're making the throat symptoms worse, you're irritating the tissue directly, and you're activating pepsin. So I do not recommend apple cider vinegar, especially for LPR. And there is no data that really shows that it helps with GERD, though there's plenty of the stories that people say, oh yeah, I swear by it, it works for me. There are many things such as licorice extracts, these are again are the items that are not really studied that do help some people. I go back, I like alginates. Alginates are very safe. It's made out of seaweed, and it's doesn't really have any significant side effects, and it really can help coat, again, as a Band-Aid to transition people to a better diet and stop the problem altogether.
Fantastic. I think that's a really good point, because I think people hear all sorts of things, or find the other planet of Google and don't and think some of these things can help, but it really is important to speak to a doctor.
Important thing is, if you're having persistent symptoms despite being treated, and even if you're better but still having symptoms, you always need to question the diagnosis and therefore look for the cause. And if it is reflux, then try something different other than drugs. And that's what I'm saying here is a dietary approach is easy to try. It is not hard to transition your diet to a more plant-based, more Mediterranean diet. And what it takes is the ability and the desire to do so. And with that, you do have Dr. Google, and you can certainly find so many references out there that will help you transition your diet. Learn about the health benefits that you get from being in a far more plant-based world, not just reflux-wise, but with heart disease and diabetes and whatnot. And what I find with my patients is I give them lots of information to read and learn about, and the more well-informed they are, the more they're likely to go down that path of being healthier and thereby stopping their reflux issues altogether.
Yeah, thank you. So, as someone was saying, I tried the Mediterranean diet and I couldn't do it completely. It was too hard. What do you suggest? So does every little bit help? Should we do the best we can?
Every little bit helps, absolutely. And I suggest a transition. Doesn't have to be done overnight. You can change over weeks or months and do it slowly. Start out with 1 day that's all plant-based, then go to 3 days, and then go to 5 days, and however that works for you. But again, reading and learning is a big important part of this. And I tell my patients, try to be 90-95% plant-based, and that translates to 3 to 4 meals a week with a few ounces of any kind of, again, animal product, not differentiating between eggs, chicken, fish, pork, steak, dairy. And that sort of gives you the health benefits that you can read about, as far as all chronic disease, and also will help with reflux disease. And many people who start going down this pathway go more and become more 98% or whatever that may be.
Terrific. Thank you. I'm going to take a couple more questions. You've been so generous with your time. Honestly, we could be here all afternoon. Stephen said, I was diagnosed with a small, forgive me if I mispronounce this, Hiatal hernia.
Hiatal hernia.
Okay. And was prescribed PPIs and Gaviscon at night. I'd prefer not to take medications for life. How can I treat GERD that may be caused by this?
Well, again, it's the same issue. Hiatal hernias are pretty much diagnosed very frequently. Whether or not they play a real role with your particular problem, that's a good question. But again, reflux is reflux. It can be treated with diet, and changing the diet can make significant changes for your symptoms. And, absolutely, you could start out with the medication approach, but with dietary change and your symptom resolution and continued follow-up, there's no reason why you can't get off some of these medications.
Well, I think you certainly made a wonderful, wonderful point here, Dr. Zalvan, and I so much appreciate your time, your expertise. You've given us so many answers, and everyone, I want you to know you can reach out to the website. I put it in the chat, entandallergy.com/booknow to make an appointment with Dr. Zalvan. And if you're not in his neck of the woods, ENT and Allergy has 40 other convenient locations throughout New York and New Jersey. But certainly see your doctor and take his ideas on diet. I think it's a great idea. I think I'm going to start rethinking my diet too. I want to be preventative and be as healthy as possible. So I thank you so much for your generosity of spirit and your information. We are so grateful that you are here with us. I want to thank all of our attendees for spending this time with us and being so engaged. Again, tomorrow you will get an email with information on how to be able to book an appointment. And then also you'll be able to get the recording of this. You can watch it again, share it with family and friends. I want to wish you all to stay safe, stay healthy, and I look forward to seeing you on a future webinar. Have a great afternoon, everyone. Bye-bye.
Good luck.